Hello, and welcome to the Mid-Atlantic Urology inaugural Men's Health and Wellness webinar. I'm Dean Laganosky, and it's really a pleasure to be with you here tonight, one of our urologists at Mid-Atlantic. So without further ado, we have a lot of ground to cover, so we'll have some time for questions at the end and hopefully delve into a little bit more detail about the specifics of the presentation. So just a little bit about my background. I'm Dean Laganosky, one of our urologists at Mid-Atlantic. I really specialize in complex voiding dysfunction, minimally invasive approaches to surgeries and procedures for the urinary tract, including robotics. Also, some urinary oncology, stone disease, men's health, and space or prostate cancer radiation. So we're going to be covering a topic tonight that is really a very common issue that affects a lot of men. So we're going to be talking about BPH, which is short for benign prostatic hyperplasia. This is a fancy terminology essentially for having a large prostate gland. This will affect most men as we age. I always say that every man, the prostate's going to grow with them. Some individuals will grow larger than others and potentially cause issues related to their urination. So it's important to note that this is not a cancerous process, very different than prostate cancer, which we'll go into a little bit more. It tends to be a very treatable condition. So it's important that you have these conversations with a healthcare provider who can help to guide you in the right direction in terms of options. So how common is this in our society? We know from the data that it affects about 50% of men who have reached the age of 50 and steadily increases throughout the lifetime to whereas 90% of individuals over the age of 80 may be affected with symptoms related to their enlarged prostate. How do men get BPH? Well, there are multiple factors, the most common of which is aging. As we are aging, our prostate glands are growing with us. There are some individuals whose prostates may be growing larger than others, so there is a genetic component. And in some situations, the hormone cascade that is in our body, specifically testosterone or other variants of testosterone, cause the prostate gland to grow, in some cases larger than others. To orient you, and we'll show a little bit about the anatomy in the upcoming slides, but I always use the analogy of the prostate gland sitting like a ball that surrounds the urination tube. So as that prostate gland is growing, it will impinge upon that urinary tube and make a smaller and smaller channel where it becomes more difficult to pass that urine. The bladder, which sits behind it, has to squeeze harder to push that urine out more effectively. So if we look here, I like this diagram because it's a side-by-side comparison of what a normal, quote unquote, lower urinary tract would look like towards the left, and then what a urinary tract affected by an enlarged prostate gland would look like on the right. So just to put the anatomy into perspective, this is the lower urinary tract. The kidneys have made the urine. It's drained down to the bladder, which is the larger circular structure here. That bladder has effectively a muscle-filled water balloon. It will generate a squeeze or a pressure to push that urine out after the urine has collected to a certain extent. That urine has to travel out a tube called the urethra, which typically comes out of a man's penis. And the prostate gland is actually making a portion of that tube very close to the bladder. So if you look at the image on the right, when that prostate gland becomes more swollen or enlarged with just a typical growth, it will actually create a smaller channel where that urine is needing to flow. The bladder may become overworked or have to squeeze harder over time to push that urine out and generate the correct pressure. It may become harder for an individual to empty their bladder, and they may have symptoms that we'll talk about related to the enlargement of their prostate gland or that strain or stress on the bladder. And just an important note here, really we've been focused over the last several decades on the effects that having an enlarged prostate gland can have on a person's bladder over time. If the bladder is squeezing what we call a stressed voiding pattern, meaning it has to squeeze harder and harder to push that urine out. Over time, that can cause some negative remodeling of the bladder and potentially damage the bladder over time, in some cases in an irreversible fashion. If the bladder is not able to compensate or generate enough of a squeeze, the bladder will begin to fail. And then we are looking at things like catheters or other means of helping the urination to come out. The goal is to try to be as preventative as possible, and early identification is key. So talk to your healthcare provider if there's something bothering you. So what are some common BPH symptoms? So this can run the gamut between a lot of different symptoms. Typically, individuals may describe a sudden, recurrent, strong sensation like they have to urinate. It's very difficult for them to hold the urination. They have to know where a bathroom is and rush to get there sometimes, or it may be too late. There are sometimes difficulties with starting the urinary flow. They have to wait around to generate enough of a pressure to start that stream of urination. Similarly, in the middle of the stream, the flow may become weaker or diminished. You may get some dribbling towards the end of the urination when the pressure has become less from the volume of urine. You may have a starting and stopping of the flow of your urine in the middle of your voiding. You may feel an urge to go to the bathroom very frequently, particularly at nighttime when the bladder becomes a bit more fatigued throughout the daily use. Nighttime urination, waking up to urinate, tends to be a very common situation with enlarged prostate glands for most men. In some situations, you may push so hard that it may cause pain or distress. And generally, this may actually cause a situation where you may not completely empty your bladder, meaning that even though your bladder is squeezing, it may not be able to generate enough pressure to push that urine out completely, and some urine starts to progressively get trapped behind. As we start to retain more and more urine, it becomes a situation where that may start to be dangerous to the urinary tract. Some individuals may get leakage of urine as well. So related to that process of not completely emptying the bladder, you can actually have some other conditions that can arise from having an enlarged prostate gland. We think about things like urinary tract infections. The number one reason why a male may get a urinary tract infection is actually incomplete bladder emptying. The urine that is left behind is a perfect source for bacteria from the skin that start to build up in that space. In some situations, if the immune system can't address that, that may cause an individual to become ill, sick with fever, or potentially contribute to sepsis, which could be life-threatening. Bladder stones, similarly, can build up from some of the sediment in that urine that's not completely draining out. That sediment may accumulate and calcify and form stones that become painful or irritative. You may get some blood in the urine or painful urination related to that. If the urine is building up to a significant amount, it may put too much pressure on the urinary tract and back up to the kidneys, causing kidney dysfunction or in some situations failure. You may get overflow incontinence, meaning that the amount of urine held on the inside may actually leak out because the muscle tissue cannot hold the urine in with enough pressure. And bladder damage can occur from increased pressures and strain on the bladder over time. It's very important, again, to say that, BPH and enlargement of the process tends to be normal growth or physiology for a lot of men that can cause symptoms in some individuals. It does not increase your cancer risk. Prostate cancer is another process entirely that can occur within the prostate gland. So what are ways that we can look at BPH and help to evaluate this if you were to come in for an evaluation? What are ways that we can give you more information as to how we are doing from the urinary pattern related to our enlargement of the prostate gland? The initial screening can come from a couple different types of evaluations. Digital rectal examination is a quick finger exam of the prostate gland. This takes about 2 to 3 seconds in the office. Basically a finger swipe from down below that would show us how large the prostate gland is. Are there any other irregularities, nodularities, or other things that may tip us off towards a cancerous process or something else contributing to your voiding issues? This is a very low risk endeavor and adds a lot of information in many cases. Bladder scans are quick ultrasounds that are done in the office. We typically would have you urinate to completion and then scan the bladder with a quick ultrasound that takes about 2 seconds to do. This shows us how much urine is actually trapped behind after you've gone to the bathroom and will give us some indication that you are holding onto urine within safe ranges. And we can also track this over time as comparison. There are some symptom scores that can help us to clarify what types of symptoms you're having related to your urination difficulties and how we can better tailor our management to you. The International Prostate Symptom Score, IPSS, is one of these. It's basically a quick survey. I oftentimes will give this to you as your intake form when you come to see me in the office. It helps to look at things like how bothersome is your urgency scale of 1 to 5. How many times per night are you waking up to urinate? Are you having any hesitancy or slow urinary stream? Rate these scores. It helps us to objectively look at this a little bit better. And then importantly, tells us how bothered you are by these symptoms as well, which is a criteria that we would use to figure out, do we need to be doing something differently, as long as the other parameters we're looking like are in safe ranges for you. There are some blood tests that can look and screen for prostate cancer. This is the PSA, or prostate-specific antigen, a simple blood test that is sometimes used alongside some of the other things we're looking at here. And then there are some urine tests that we can run quickly from a sample provided in the office to look for blood in the urine or infection. So other things that we can use to help to clarify ways that your bladder are emptying, and look at things like pressure and flow studies to tell us how safe the bladder avoiding habits are that you have. Some of these are very non-invasive. They're quick to do. You'll come to the office with a full bladder and you basically urinate into a machine. The Urocuff is the one that I would typically look at here. Basically a small cap that has a vacuum device, sits on the tip of the penis. You urinate into this machine and it provides a little bit of a squeeze or a pressure resistance against your urination. We get a couple data points to say, how hard is your bladder working with the pressure that's needing to generate to push the urine out, and what is the flow looking like? Are we staying in safe ranges with the current way that we're managing your symptoms, or should we be considering other additional types of therapies to keep your bladder healthy? Urodynamics is a more comprehensive test that is a little bit more detailed and can look at some of the bladder function a little bit more closely. This is another thing that we sometimes consider if we can't get all the information we need with non-invasive flow study. This takes about 45 minutes done in the office. It does require a brief catheter to fill up the bladder, but it would give us a lot of information in terms of how well your bladder is able to squeeze, generate a pressure. Is your bladder overactive, or should we be thinking about other things to target your voiding symptoms? And then there are some other types of diagnostics we can think about as well. A cystoscope is a very quick and straightforward office-based evaluation. This involves a quick look with a camera from down below. Now, I always say everybody looks at me with two heads when I say we're taking a camera look down below, but it is very straightforward. Most individuals would describe a sensation that they have to urinate because we fill the bladder with not only a little bit of numbing jelly, but some fluid as we're taking a look. I take some pictures and images to show us what the anatomy is looking like to help to better figure out a game plan in terms of next steps in management. This can show us some information specifically about the anatomy. It shows us if that prostate gland looks like it's blocking the way and how it is appearing in terms of its contours and its shape. That helps us to tailor decisions for us. It can also show us, are there other things that could be blocking the flow? Things like strictures or narrowing or scar tissue, which could be another reason why you may not be emptying your bladder fully. It can look for things like stones or tumors or irregular tissue in the bladder, and also sources of blood in the urine or other sources for recurrent infection that we should be thinking about or addressing. And it can also give us a general survey of the bladder tissue to say, is the tissue looking regular, or how stressed of a change has squeezing against that prostate gland caused over time. Other tests that we sometimes utilize as part of this workup, not necessarily in every case, there are ways that we can accurately size the prostate gland with a quick ultrasound down below. This is similar to the finger exam. It takes about 2 minutes to do, and it can accurately show us the shape of the prostate gland visually with an ultrasound. It can also clarify the size and if there are any other irregularities. In some situations, we can also take samples of the prostate tissue to ensure that there is no cancerous process or other irregularities. We would really only consider that if we have some indication that there's an abnormal rectal examination or other testing like your prostate levels are too elevated and we don't have another explanation. Again, a very straightforward endeavor, typically if we have to pursue that. So we've talked about the diagnostics that we typically use. Now we'll go into an overview of some of the management options for how we can improve urinary symptoms if they are present. So this will range from lifestyle changes all the way up to different procedural options, all of which tend to be minimally invasive for the most part. So we'll start with lifestyle changes. There are some habits that can be helpful for individuals who are struggling with urination to help them to manage their symptoms a little bit better. Generally, we talk about techniques to help you relax when you are trying to pass the urination and do techniques like double voiding. What this typically entails is you urinate to completion as best as you can the first time. You take a break, take some slow, deep breaths, try some relaxation techniques, and then you try to empty more completely the second time. This helps to address if there are any leftover residuals remaining in the bladder, would help the bladder to kind of recover and generate a secondary squeeze to empty a little bit better. Some individuals find success at minimizing nighttime fluid intake. What we put in typically has to come out, and it may take several hours for you to process those fluids. So typically I say if you can reduce the amount of fluid that you're drinking by to less than about 6 to 8 ounce fluid serving after dinner time, that may help with some of the nighttime urination symptoms. And we do know that there are certain foods and drinks that may irritate the bladder and make you go more frequently or urgently, particularly if you have an enlarged prostate. This is things that are caffeinated beverages, coffees, teas, yes, even decaf coffee does have about 50% of the caffeine that a regular coffee would. So things that you may want to target or minimize to see if they're helping your symptoms. Sodas, carbonated beverages are other potential possibilities for irritation. Alcohol will typically push more fluid as a diuretic through the system, and individuals who are not processing that fluid well may have some issues. Citrus, spicy or sugary foods may also irritate the bladder, tomato-based products, and chocolate. Some lifestyle changes to also be aware of. There are certain medications for individuals who are struggling with urination to be aware of, as they may it will worsen or exacerbate the way that you are able to empty your bladder. So we think about things that are antihistamines or anti-allergens. Typical ones are Benadryl, Allegra, Zyrtec. These are ones that can actually slow the squeezing of the bladder, which if you're already needing to generate more of a pressure to push that urine out, any slowing of that process may make you hold on to more urine, sometimes to a dangerous amount. Decongestants may increase the tone or resistance where the bladder would have to squeeze against, again, making you hold on to too much urine. Valium may slow the squeezing, and opioids can have a couple different effects on the urinary tract, one of which is actually causing constipation, which tends to be the enemy for individuals who are having a hard time emptying their bladder. So constipation management is very key. What we think about here is there's a big interplay between the bowel function and the bladder function. There's only so much room down in the pelvis. So if you are backed up with stool, it's going to put a lot of pressure on the bladder and may make it more difficult for you to fully empty your bladder. So the goal is as feasible or achievable to get you as close to a daily soft bowel movement as we can. It's not always possible, but the better we can get the bowels, the better the urination may follow. And then I would just put out a word of caution. You will see a lot of things advertised in terms of over-the-counter miracle supplements that will help your prostate gland. I generally find that some of these may not have a lot of data supporting them. It's probably best to talk to your urologist or specialist when you're considering some of those options as part of your health plan. Medication therapies are another good option for many individuals. These can help to manage most symptoms of BPH, especially if they are mild to moderate symptoms. The major classes of medications are alpha blockers. These are things like tamsulosin, alfuzosin, silodosin. You can see some of the names down there in terms of the brand names that we would think about. What these medications are relaxation medications targeted to the capsule around the prostate. So again, use that analogy as a ball, the prostate gland sitting around the urinary tract. As it is growing, it's constricting. What these medications do is they cause a relaxation and may widen that urination tube, helping the urine to flow better. It's important to note that these medications really aren't doing anything to shrink down that prostate gland. When you come off these medications, your symptoms will typically regress to where they were before. But these can provide effective management for some individuals. 5-alpha reductase inhibitors, these are things like finasteride or dutasteride. Brand names are Proscar and Avodart. What these ones do are they can actually shrink down the prostate. They work on the growth signals to the prostate gland, but they are slow to act. Sometimes it takes up to about 3 to 6 months to see full benefit. In some situations, a bit longer. But by reducing the size of the prostate gland, there's less tissue in the way and the urine will flow a little bit better. Some individuals take both medications side by side. A note is that tadalafil in a low dose, which is a low dose form of Cialis, can also provide a mild relaxation effect on the prostate gland and can be used for both enlarged prostate management, avoiding dysfunction, as well as erectile dysfunction as a third medication option. So then we move on to other options that include minimally invasive camera-based procedures. These are great options for individuals who may not be able to reach desired urination patterns despite medication therapy, or who are not interested in continuing medication therapy long-term as maintenance. These can really get us off medications and help to kind of offload that prostate gland so the bladder is far less stressed, keeping that healthier over time. Some testing initially may indicate that we need to consider these on a sooner basis, particularly if you're holding on to a more dangerous amount of urination or we're seeing some concerning signs on the workup. It's important to note that most of these procedures are covered by many major insurance providers, and we have specialists typically through the office who will work with you and your insurance plan to ensure that things are pre-certed, and we can kind of answer questions to make sure that these things are kind of ironed out before we would go down this route. So one of the first options, a very good option for many patients, is the Urolift system. This is a procedure where we put small flexible implants within the prostate gland to open up that prostate channel and create a wider channel where the urine is going to flow. The analogy I typically use for my patients is opening up the curtains on a stage and creating kind of a wider channel. It's quick in terms of the recovery as well as the procedure itself. Has one of the shortest catheter times that we typically offer patients and gives good long-term durable outcomes in many individuals. We have to select individuals well for the shape of their prostate gland and the size, but that is part of that workup that we would do to help to tailor this option for you. You'll find that as we go through kind of a risk benefit of each of these procedures, most procedures that we be talking about are camera based, so no incisions, not a major recovery process for most of the things that we're talking about compared to an incision based surgery. Most of these procedures are going to cause some irritation with the urination as the most common symptom afterwards. It's urgency, frequency to urinate, some blood tinge to the urine, as well as potentially some debris or burning sensation with the urination. With Urolift, this typically tends to last about 7 to 10 days, may linger up to several weeks afterwards, depending on some factors. It has a very low risk, one of the lowest risks of any erectile dysfunction or ejaculatory dysfunction, which is a big selling point for this type of procedure for many men, and can help us to get off of medication therapies, keep our bladders and urinary tracts healthy long term. There's not a major recovery process here. One of the caveats, though, is because these are small needle punctures, we really are not removing tissue, so we can't really sample that tissue further, but the goal is to create a nice wide channel where that urine is going to flow as the goal of the procedure. Brings us to our next option, which is Rezum. This is a water steam vapor therapy where we are going to shrink down the prostate gland. The analogy I will typically use here is think about the prostate gland as a grape. When we put this steam treatment at a couple targeted locations, we are shrinking that down to a raisin. And so less tissue in the way due to that involution process, a wider channel where that urine can flow. This is sterile water vapor. It's typically done as an outpatient procedure, would not require a general anesthesia. Each steam treatment is about 9 seconds. Most individuals will get between 4 and 6 of these steam treatments targeted to the tissue that's most obstructive. And then that will cause an involution or a shrinkage of that prostate gland that may take a variable amount of time for each individual as we process that inflammation. So most individuals will see some symptom relief at about 2 weeks. It may take some individuals up to 4 to 6 weeks to reach their pre-voiding, pre-procedure state. You may see some slow improvement up to about 3 to 4 months in some situations. What is key here is, we're allowing your body to process that inflammation here, and that inflammation is doing a lot of the work in terms of shrinking down that prostate gland. You may have a little bit more irritation, blood, burning sensation, or debris passage in the urine compared to Urolift, but we are shrinking down that prostate tissue over time. Some inflammation can linger in the prostate, leading to burning sensation, and in some situations, some pain with ejaculation. In rare situations, would this ever cause a narrowing of the urinary tract or recurrent urinary retention? Again, very low risk of any type of ejaculation issues, less than 1%, and certainly low risk of any type of erectile dysfunction, making this a very ideal procedure for many individuals. You may require a catheter for up to 3 to 5 days, depending on how much work is done at the time of your procedure. And we are actually physically impacting the prostate tissue with this. This brings us to our next procedure, which is transurethral resection of the prostate. This is kind of the gold standard, longest standing procedure, again, done through a camera, so no incisions and limited recovery time compared to major procedures. Think about this as going in with a camera while you are asleep for this one. We are coring out that prostate gland similar to coring out an apple, creating a nice wide channel where that urine will flow more effectively. This is kind of the gold standard that we compare a lot of the treatments to. So it will require general anesthesia. I'll tell you, full disclosure, most of my patients will go home as a same-day procedure as an outpatient. There are some situations where we may consider an overnight observation. Typical catheter time in my individuals who go forward with the surgery is about 1 day and up to 3 days in some select individuals. This is really a very effective long-term management option for many patients. You'll have this typical irritation with voiding, some blood in the urine that may last several days to several weeks, typically most pronounced for about 7 to 10 days. We are removing chips of that prostate all through our camera that we can send for evaluations of things like cancer as well, which is another helpful evaluation here. And the one key here is that this may cause, in many individuals, about 75 to 80% of individuals, decreased amounts of ejaculate after the procedure. This will typically settle out to its new baseline about 6 to 8 months. In some situations, maybe lifelong. It's not a dangerous thing. And the reason this happens is because we are removing that prostate tissue and creating a wider channel. some of the ejaculate may slip backwards into the bladder and then be urinated out afterwards. We call it retrograde ejaculation. Again, not dangerous, but you will notice a decrease in the amount of ejaculate specifically with this procedure. Aquablation is a good alternative to many patients undergoing TURP, and for some individuals, even with smaller or larger prostate glands. This is one of the newer treatment options, and we use a heat-free water jet that basically will vaporize that prostate tissue and remove more tissue than what you're typically going to get with some of the other kind of options that we have talked about. The neat part about this procedure is that we use a robot to help to very carefully map and tailor that water jet that works within a millimeter to a half millimeter of precision. What this does is we map out while you are asleep with anesthesia the contours of the prostate in every area that we very tightly would regulate to try to treat here. This would typically require an overnight stay in the hospital and would typically have a catheter in place for about 5 to 7 days post-procedurally. You would expect typically some burning with urination, some blood with the urination thereafter. There's very rare risk of any damage to the urinary tract organs as this is very tightly robotically regulated. The nice part about this compared to traditional TURP is there's really no impact on erectile dysfunction or ejaculation issues. 99% of men maintain continence control and preserve ejaculation after this type of procedure. It may require a catheter time that's a little bit longer than traditional shaving, but again, that catheter time is kind of an upfront catheter for a long-term benefit. And the nice part about this is it can even be considered in very large prostate glands, cutting down procedure time to about 15 minutes to about 25 minutes. Holmium laser enucleation of the prostate gland, or HOLEP, is another alternative for larger prostate glands. Done with the camera, we use a laser to core out that prostate. And then we basically take out the prostate gland, similar to taking out the inside of an orange while leaving the peel. This is ideal for larger prostate glands, may require a night in the hospital or several days in the hospital thereafter, and is a general anesthesia procedure. Our catheter may stay in at least several days post-procedurally. Ejaculation dysfunction is common with this for the same reasons that would be common with TURP, removing the tissue. But there's a very low risk of any erectile dysfunction. There may be a little bit of downtime after this type of procedure compared to some of the other options that we've talked about. And the tissue can be removed for evaluations of cancerous processes as well. And then, simple prostatectomy is really an option that's very well suited for folks with very large prostate glands or a little bit more of a complicated type of anatomy. This is an incision-based procedure versus the other options that we talked about. Simple refers to a non-cancer procedure versus a radical prostatectomy, which is done more for a cancerous process. This has really come a long way in terms of this procedure. When we do this, we'll typically do it through a robotic approach, small incisions, but still an incision-based surgery done through the belly to remove the inside of a larger prostate gland, create a wider channel where the urine will flow. This will require an overnight stay in the hospital, potentially several days in the hospital, and there is a recovery period that would require a catheter for up to about 7 days. There may be a downtime associated with the recovery process with this procedure, typically of about 4 to 6 weeks in terms of the overall recovery process, heavy lifting restrictions and trying to limit strenuous physical activity thereafter while you're healing from the procedure. But most individuals will be able to ambulate, use stairs, eat and drink as usual, very quickly after the procedure. Again, because we're removing a lot of prostate tissue here, ejaculation issues can be common, as can some blood in the urinary tract. There is a very low risk overall of bladder damage or urethral damage with this type of procedure, especially with the robotic approach and more advanced visualization. tends to be a very good option for large prostate glands alongside HOLUP and aquablation. So that is our whirlwind tour of prostate management for enlargement. I will just leave you before we start the question section with my 2 cents, which is, there are so many good options for ways that we can manage your enlarged prostate symptoms. And what I always advocate for is to make sure that if something is bothering you, whether it be urologic or not, that you get checked out and you meet with someone who can help to work through some of these issues with you. We can provide a workup and kind of a tailored management option that will give you the confidence that we're making good, sound decisions for you and your health long term. So if there is something bothering you, please get checked out. And we're more than willing and able to kind of tailor these things in a very individualized fashion for you. So with that being said, we'll open up the floor to some questions. And again, thank you for spending the time with me tonight to talk about BPH. All right. So I'm going to go through a couple questions that we have here in front of us. So the first question that we have here is about prostate artery embolization as another option or alternative here. What this is another option that is typically done through a radiologist or an interventionalist. It's a minimally invasive procedure that kind of indirectly affects the voiding. It's done through a small needle puncture, typically with a little bit of sedation, and a radiologist uses an image to kind of plug some of the blood flow to the prostate gland. In that way, it may decrease the size of the prostate by limiting some of the selected blood flow. And you're really banking on that kind of targeted shrinking as shrinking the right type of tissue that's causing the blockage. In some situations, that may not be the most targeted approach compared to some of the options that we're kind of directly visualizing the tissue that's causing the obstruction, but nonetheless a good option for some individuals who either may not be surgical candidates or considering other kind of alternatives to the things that we were just talking about. Certainly would be helpful to meet with your urologist so we can come up with a tailored option from that standpoint. So next question, does Urolift compromise MRI? So remember, Urolift is the implant surgery. These are small, safe surgical clips with a suture material similar to what's used in other areas of the body for surgeries. Urolift tends to be MRI compatible, should not impact many newer MRI scans. And I also say you're not going to set off any airport metal detectors as well. Another question about Gemtesa as a bladder-based therapy. How effective is it and how is this working? How long does it take to work? Gemtesa is another medication not really focused to the prostate gland, but more focused to the bladder. It can help with urgency or overactivity, some of the symptoms that can sometimes go alongside prostate enlargement and symptoms related to it. What we find is that sometimes the stress of squeezing over time to push that urine out against a large prostate gland may actually drive the bladder to be the source of some urgency and frequency. What we find is getting to the source of this, addressing the prostate gland may overall help this and to help to reduce some of the obstruction that's actually leading to the problem. What we will find is that Gemtesa may be a good supplement, but the problem may be that Gemtesa and some of the other medications like Myrbetriq or anticholinergic medications, trospium, oxybutynin, may actually slow bladder squeezing, make you hold on to more urine, and actually worsen symptoms of BPH if you're not completely emptying. It does take several weeks, about 4 to 6 weeks to really work fully though. Other option, so another set of questions here. What is best procedural options to reduce the prostate size and eliminate retrograde ejaculation? So, retrograde ejaculation is again one of those risks that's associated with typically removal of the prostate gland. The lowest risk of that would be with Urolift, um, potentially Rezum, or potentially aquablation. It's more common in situations of TURP or the resection, HOLEP, or simple prostatectomy. In terms of what the best option would be, I would say that it has to be tailored to the individual based on some of the workup that we would typically perform. I have a question here about what types of options last the longest. Some of the resective options, TURP, aqua ablation, HOLEP, or simple prostatectomy, by simply removing more prostate tissue, may have longer outcomes for you. Rezum and Urolift tend to be good long-term options, and we have, in some cases, up to 10-year data that say these are sustainable results. So we would typically monitor this closely afterwards with your urologist to see how you've responded to the treatments, and then evaluate going forward to see how those changes over time from the surgery are sustained. I have a question about a couple questions about different offices potentially offering certain types of procedures versus others. What I will say is this, right? As somebody who offers a comprehensive range of options for management of urinary tract dysfunction, if there's questions or concerns about potentially not having options at certain locations. I mean, what I typically will say is, it's totally fine to look around to see who may be a good provider option, to be able to talk with you about some options outside of what's typically being offered to you. There may be some reasons based on your anatomy or your presentation that would make one option or procedure a little bit better suited than another. So we can help to sort that out with you. And certainly, having a benefit of Mid-Atlantic Urology, for instance, is that we have so many different provider options throughout our comprehensive network that certainly there are options for you to meet with someone who specializes in many different types of options that you may be interested in. All right, so I have question about BPH causing a rise in PSA. So PSA, again, is the blood test that is typically an initial screening test for prostate cancer. But I say PSA is prostate specific and not cancer specific. So there are plenty of things that can cause PSA values to rise. Enlargement of the prostate gland, more tissue will make more PSA. Inflammation of the prostate may release more PSA. Prostate cancer is one of the things that we look for. So yes, to answer your question, larger glands may cause more PSA to be released. But what I would typically recommend is you would have kind of an evaluation to explain why the PSA is elevated, and to make sure that that is a safe reason that doesn't need to be investigated further. I have a question here about intermittency of symptoms. So, it's question is basically, can some of my BPH symptoms come and go? Oftentimes, many individuals will have a waxing and waning course for their urinary symptoms. What you may find is that many individuals will get to a tipping point where some of the symptoms they experience may come and go, but may become more frequent over time or more sustained over time as that prostate gland continues to enlarge and the bladder is having to work harder and harder. So yes, we do see that these symptoms can be periodic, but I would argue that that's the perfect time frame to be having some of these conversations, because it's an early intervention and we can talk about a lot more options that may be well suited on a preventative as opposed to a reactive basis. I have a question about Urolift and customization of the urethral channel, how we would apply these implants. So yes, the implants for the Urolift or the steam treatments for a Rezum, or the way that we would target the tissue with an aquablation, whole lip, or a chirp resection is customizable and really tailored to what tissue is causing the most obstruction. For Urolift specifically, we would place these implants in a fashion that would really give you the maximal widening of that channel for the urine to flow, targeted to the tissue that would be most obstructive. So I have a question for individuals who have a diagnosis of prostate cancer and may be considering radiation therapy, which is one of the major ways that we treat prostate cancer. Can the flow of urine improve after radiation therapy? The answer is potentially yes. The radiation actually causes a shrinkage or a fibrosis of the prostate tissue, and in some situations, causing an involution of the prostate may reduce some of the constriction of that prostate gland and potentially improve flow. It's a case-by-case basis from that standpoint. There are some individuals who we know may be predisposed to urination issues, and we monitor very closely either before or after radiation to make sure they're emptying their bladder well and that their symptoms are not worsening where they need to consider other options for their urination. I have a good question here about iTind and some of the other options that are meant to be a little less permanent options that kind of bridge the gap between medication therapy and some of the other procedures we talked about that would be kind of more permanent options for addressing that prostate and the outflow obstruction. iTind is one of several different urethral expanders. This is a small basket-like structure that is made of some nitinol wire. It's a benign substance that basically can be put into the urethra right around the area of the prostate gland. When we deploy this basket, if you will, it expands the urethra and pushes the prostate gland out of the way. It does require this basket to stay in to allow a widening of that urethral channel, and may give individuals an indication of how well they're able to void when that prostate gland is moved out of the way. This is not meant to be necessarily a permanent option and does need to get exchanged periodically, but it can be a good option for some individuals. I have a question about bowel habits and specifically irritable bowel syndrome, which can either cause constipation or looser bowel movements. Can this affect urination? Certainly. We do see that bowel habits, either inflammation of the bowel, irritation of the bowel, or frequent diarrhea or constipation, may impact the urinary tract as well, given the proximity of those structures. So what we would look for there to see how much of an impact that may be causing is when symptoms are a bit better controlled from the bowel habits, are we seeing a correlation of the urination symptoms also follow, or are some of the same urination symptoms present with or without the bowel symptoms? TURP, I have another question about TURP or another alternative to TURP, which is done with a laser called a green light. Can that be a lifetime treatment? Or can the prostate gland grow back after several years? The data that we have is long-term data for those particular procedures, about 1.2% retreatment rate over about 10 to 15 years. So it's meant to be a lifetime or a long-term solution for many individuals. You're right in saying that the same factors that have caused the prostate gland to grow over the course of your lifetime for that enlargement before the procedure may still be in place and cause that prostate gland to regrow. But generally, that is a very slow process over time. It's taking your body its entire life to kind of have its prostate gland grow to that size. So if we are ever seeing any regrowth, it's slower over time and can always be touched up if needed with either a re-resection or some of these other options in a less extensive fashion than the initial procedure. I have a question about individuals with bladder cancer, and can that impact what type of treatment can be done? Most well-controlled bladder cancer that has been treated may not necessarily impact your outcomes with your procedures for your prostate gland. Again, this will be very tailored to your kind of individual presentation. What I will say is that sometimes bladder cancer can cause a little bit of irritation of the urination, some blood with urination. And as you are healing, you may have a little bit more urgency, frequency to urinate, or can impact the way your bladder squeezes it a little bit, as you're recovering. So those are some considerations that we would think about on a tailored basis for you. These are very good questions. Appreciate you guys putting these out there. I hope this is helpful. I have a question about prostatitis, which is inflammation of the prostate gland. This is another condition where inflammation may cause a swelling of that prostate gland and then cause that swelling to impact the flow of urine as well. Typically, irritation or inflammation in the prostate may actually be a driver for some urgency, frequency, and blood tinge to the urine, even without the prostate gland being large. So some individuals, even with a large prostate gland, may also have some inflammation in the prostate gland that can also be the driver for their symptoms. We sometimes will treat this a little bit differently with antibiotics to reduce that inflammation if it's due to an infection, or some anti-inflammatories and lifestyle changes that can also help to reduce inflammation within the prostate and reduce some of those symptoms. We try to get those as ironed out as possible, and then consider some concurrent treatments for enlargement of the prostate if that's also present. I have a question here about radical prostate removal, which radical prostatectomy is typically done for a cancer process. Cancer can occur in large prostates or small prostates. So if the prostate gland is enlarged and you remove that prostate gland for the cancer surgery, having that prostate out of the way can actually help the urine to flow a bit easier without that obstruction in place. We would typically monitor afterwards to see how well we're emptying the bladder, and that would help us to gauge how much of an effect that type of procedure has had. I have a question about kind of durability of some of the procedures. If an individual has had a prior procedure with a Urolift or other type of minimally invasive option some years ago, and we're starting to see some slowing of the urinary stream, would that indicate that the prostate gland is kind of growing back? Potentially. I mean, one option that we would look at there are some non-invasive tests such as the Urocuff that could tell us, is this truly prostate flow obstruction in a non-invasive fashion, or is this something to consider about the bladder? Camera looks can also determine, is that prostate gland bulging or kind of growing back? And we can help to kind of delineate that a little bit better to come up with some targeted options. Can you take an over-the-counter supplement with alfuzosin? Many over-the-counter supplements that you'd be talking about here for prostate health would typically be saw palmetto based, which is a same active ingredient as some of the other medications we talked about earlier for shrinking that prostate gland. Yes, is the answer that I would typically give here. It would depend on what is in that supplement. And I would oftentimes tell you that it's probably safe to take alongside the alfuzosin, but always good to check specifically with your urologist so we can go over kind of in a little bit more detail for that specific supplement. I have a question about, can a Urolift or an implant be removed if necessary? And the answer is yes. There are some individuals who, if we are seeing any return of voiding issues, after a Urolift or those implants are in place, I see many individuals for a second or third opinion about their voiding issues. And there are definitely ways that you can remove those implants, typically with a same type of resection in a camera-based fashion as is done with a TURP, or through aquablation or some of the other resective modalities. So answer is yes, and would depend on the specific situation, but in many cases wouldn't be a reason to think that you wouldn't be able to get those removed. I have a question about HOLEP, which is the holmium laser enucleation of the prostate gland. Again, the coring out of the prostate, similar to removing the orange while leaving the peel. Is that the same as a green light laser? A little bit different. The green light laser is a laser that's used to vaporize the prostate tissue. That one is kind of more akin to the TURP procedure, which is kind of coring out that prostate to create a wider channel. HOLEP is a little bit more extensive, uses a laser to take more prostate tissue as opposed to the green light. Recovery time for green light is probably more similar to the TURP as opposed to the HOLEP. Are there certain foods to avoid with BPH? We've looked at a lot of dietary types of supplements and ingredients, and a lot of them have not really held up in the clinical trial space, particularly that and for prostate cancer, prevention. What I will tell you is that some of the medications and the dietary supplements, foods and drinks that we listed that are bladder irritants would be good things and as target points to think about, to try to avoid, but nothing that would necessarily shrink down that prostate gland further. That process is more physiologic and related to testosterone and other hormone influences, as well as genetics and aging process that will cause that prostate gland to grow. I have a question about low-dose finasteride, which is Propecia, sometimes used in low quantities for hair loss. It's a little bit of a lower dose than what we typically would give for urinary tract management and voiding issues. But yes, to some extent, you may see some benefit being on Propecia or lower dose finasteride, shrinking down that prostate gland to a lesser extent compared to the higher dose that we would typically use, which is 5 milligrams compared to 1 milligram. Question about BPH medications and will you eventually need a procedure? There are some patients who can be on medication therapy long-term, as long as they're seeing stabilization of their voiding habits and we're not seeing any dangerous progression in terms of that bladder remodeling. What I would typically say is a lot of the testing that we would do, specifically the Eurocuff, would tell us kind of, is the pressure generated by the bladder staying in a safe range? Is the flow parameter also staying in a safe range as part of that monitoring for folks on medication therapy? So that's the way that I would typically gauge, are the medications working or doing what we need to be doing, or should we be considering any other types of options for you? I have a question just relating to age and, voiding symptoms. And is it am I too old, or do I have other comorbidities that may stop me from getting some of the options that we talked about? I will tell you that, these types of procedures, because they're so minimally invasive, may be good options that are well tolerated for individuals who are, concerned about their age or other comorbidities. There's not a major recovery process with some of these things. And, I sometimes think about these types of procedures for folks who have catheters as well and can't break the cycle of a catheter because they are not able to empty their bladder. So I would tell you it's a case-by-case type of decision there, but really engaging with your urologist to try to figure out what the best option would be. I wouldn't think these things would necessarily be off the table for you. So I know we're running a little tight on time here. I just wanted to thank everybody again for your attention tonight, and really my pleasure to be able to talk with you. If I can be of any help to any of you as we go forward, please don't hesitate to reach out. I have full confidence in many of my colleagues around Mid-Atlantic urology. Many of us are very well versed in some of these options I talked to you about tonight. And again, my pitch to you would be, if something is bothersome to you, work with your urologist, partner with us so we can help to come up with a tailored option that's individualized to you and your symptom control. I hope everybody has a wonderful night and that you found this informative. I wish everybody to be safe and well, and we'll talk with you soon.